All right, let's get started. My name is Bob Constantine. I'm with the Florida Mental Health Institute at the University of South Florida. I'm going to facilitate this evening's agenda. Okay, so welcome to this second meeting of the medical directors of the SIP facilities. We were talking a little bit earlier saying, you know, who's going to show up? And we said, well, it's a pretty good group, so it must have been halfway decent the last time, since many of the people that were here at last year's meeting are here again. So we're glad of that. This meeting is really sponsored by, ultimately by the Agency for Healthcare Administration and Medicaid, but there are two components to that, two contracts that are underwriting the cost of this. The first is the Medicaid Drug Therapy Management Program for Behavioral Health, and I'm the director of that program, and I'll talk a little bit about that in a minute. And the other is a contract that the Florida Mental Health Institute has to do a variety of evaluations for the agency, one of which is evaluations of various out-of-home care programs, SIP being one of those. So it's those two contracts that together are underwriting the event. These are the program goals that Chapter 4 and 9912 is Florida statutes. This program was actually created by the legislature as a part of Medicaid reform legislation that was passed in 2005. And these are pretty much word for word the goals of the program as described in the legislation. This is sort of a summary of the different activities that the program does, and it has a certain logic and sequence to it. So we start with development of evidence-based guidelines. From those guidelines and the expert panel that we use to create them and update them, we get recommendations for what we call complex care indicators. Those indicators are used in the analysis of Medicaid pharmacy claims. We use those claims to identify patients who are getting unusual prescriptions that don't appear to be evidence-based. We identify physicians who are writing those prescriptions in large numbers. We do a variety of interventions with them, and then we do ongoing surveillance on a quarterly basis, looking at the practices not only of those physicians that we intervened with, but all the physicians. And the hope is to try to reduce over time the number of patients that are getting unusual prescriptions, recognizing that some patients only do well on unusual prescriptions, so we're not going to eradicate them, but our guess is there are probably some that could be eliminated. So the guideline development process, we do a guideline expert panel meeting every year. One year we do adults, the alternate year we do children. We bring in usually 3 or 4 top national experts, researchers and clinicians on the specific disorders that we're developing guidelines on. We also bring in representatives from the Florida medical community, people that work in agencies, people that work in private practice. With the child guidelines, we bring pediatricians in, developmental pediatricians usually. We try to make them educational, user-friendly, and they're probably, I think, still the most current guidelines out there because we update them every year and incorporate any new research that's been published. So this is a list of the guidelines that are available, and that's the website on the bottom. I'm sure all of you study that website on an almost daily basis. If you haven't gone onto it, I would encourage you to do so, because it's not just the guidelines. There's an incredible amount of information, video presentations from the national experts on these various disorders, reviews of research in the treatment of disorders. So there's a huge amount of information that's worth checking out. All right, as I mentioned, we're now calling these UPMIs, these indicators that we use as data filters to try to identify unusual prescribing practices. So they're derived from the guidelines. The expert panel that does the guidelines also recommends these UPMI. As I said, we use them to analyze pharmacy claims. Their definition is sort of less well supported. They're practices, prescribing practices that are less well supported by evidence and that may produce marginal benefits and or complete risk. Therefore, they generally should be used only after other better supported practices are used, and therefore they should be relatively rare. And because of that, they warrant greater review or scrutiny. So that's our justification for actually identifying physicians and intervening with them when they're writing lots of prescriptions that are hitting these indicators. This is a list of the original indicators that our last expert panel recommended to us. And I'll talk about what we're focusing on in the last year or two recently. I won't read these to you, but you can see they relate to polypharmacy and they relate to high dosing kinds of indicators. So as I mentioned earlier, in the quarterly analysis, first we identify the patients that got the unusual prescriptions, then we identify the prescribers of those prescriptions, then we rank those prescribers from high to low in terms of the number of prescriptions and patients that hit the indicators. And we try to develop peer groups, and in fact, you guys are one such group. So community mental health physicians as opposed to physicians in private practice, physicians who are treating patients in assertive community treatment teams, which are an unusual and really severe group of people. So we've tried to parse it out so that when physicians get information about their practices, they have a comparison with somebody that they're more likely to think is a reasonable comparison. Right, the interventions in order of intensity. First, we send letters. The letters are sent to physicians who are high up, usually for children. It's the top 100 physicians in the Medicaid fee-for-service system ranked by the number of patients that they treated that got these unusual, that hit these indicators, that were writing unusual prescriptions. The letters say, we've identified this practice, you're among the highest using it. Here are the patients that that Medicaid claims shows got these prescriptions. We encourage you to review what you're doing, and here's a summary of the literature that indicates that it is, in fact, an unusual practice and generally should be relatively rare. If the letters don't reduce the frequency with which an individual prescriber is hitting these edits, we send a pharmacist to talk face-to-face with the physician. We do some medical records reviews of patients that hit the indicators from those physicians, try to get a better idea of the nature of the practice of the physician and the rationale for the unusual prescribing patterns. And then the last thing we do is face-to-face psychiatric consultation where a consulting psychiatrist, board-certified psychiatrist, meets with individual physicians, usually in their office, discusses the practices, has lists of the patients, their recent patients that hit the indicators, has information about how high they are in terms of their peers. And then that psychiatrist also reviews a small sample of records from those patients, hopefully with the physician involved. And probably 2/3 of them, it actually works out that way. The response to this has been better than I thought. So this is the list of unusual practices for child and adolescents. As I said, you've got them in your packet. They relate to either polypharmacy or high dosing or the use of antipsychotics or stimulants with very young children. So one of the indicators is use of antipsychotics for children under 5. Another one is use of stimulants for children under 4. The polypharmacy is 4 psychotherapeutic medications at the same time for more than 90 days, and antipsychotic polypharmacy 2 or more antipsychotics for more than 45 days. We've now switched that to 60 days. So those are the indicators. Actually have this pointer here. Point out a couple of things in terms of which indicators were hit most frequently during this period, which is 2007-2008 fiscal year. So the highest frequency ones were high dose, and by the way, the dosages are set by the expert panel, and they're published on the website. And for a number of medications, the doses in our guidelines are higher than the FDA guidelines because experience has indicated that that seemed reasonable. So the high dose and the 2 or more antipsychotics for more than 45 days were the most frequent, followed by children 0 to 5 on antipsychotics or antidepressants. One of the things we discovered fairly early on in looking at this was that the prevalence of prescriptions that are hitting these indicators are not evenly spread among the prescribers in the Medicaid program that are writing prescriptions for psychotherapeutic meds. They tend to be concentrated in a relatively small group of physicians. So quantifying that from the point of view of the data that was in that previous table, see 10% of prescribers accounted for 54% of all the psychotherapeutic meds and 63% of all the total UPMI, of all the prescriptions that hit these indicators. For the antipsychotic ones, 10% of prescribers accounted for 76% of all antipsychotic patients and 83% of all patients who were treated with 2 or more antipsychotics. So that shows you the extent to which the practice is concentrated in a relatively small number of physicians. 10% are accounting for 75 to 80% of the prescriptions and the prescriptions in patients that are hitting these unusual prescribing indicators. So putting that slide that showed the distribution of the different indicators together with the last slide that shows how concentrated within prescribers these practices tend to be, what we decided to do starting in the second half of 2008 is first of all to focus on treating patients with 2 antipsychotics for 60 days. Focus on that particular edit, which was the highest for children. For adults, it's like 10 times higher than any of the other indicators. So children who are getting antipsychotics before they turn 6 years old are now subject to prior authorization. And we're focusing our interventions on the top 10% of the prescribers who treated most of the patients that got 2 or more antipsychotics. So top 10% of the patients, this particular indicator, with the thinking that if we could really focus on this one practice, we might be able to have an impact on it. The intervention we used in the last year and a half or so to address the indicator and those top 10 physicians was the psychiatric consultation, the furthest down in terms of intensity, the most intense intervention. And the reason we did that is because virtually all of the physicians that are on the top of this list have been there for quite a long time, and they've gotten multiple other interventions. So it seemed like it was time to have a face-to-face meeting with their peer to talk about what was going on. So this is sort of the protocol. Review the prescriber's history of RX that triggered the indicators, comparison with their peers, questions and discussion about the nature of the practice of that particular physician, which has been very helpful in some instances. So we share the guidelines and the literature summaries and request careful review of the practices.